Let us join together in a nice case of myoma resection, starting by vaginoscopy, approaching the external os, push fluid to open cervical canal and access to the uterine cavity. Give it time and put in your mind, because of the 30-degree nature of the lens, you will be seeing more of the anterior wall. To look at this lateral wall myoma, you have to rotate the light cable or rotate the whole camera so you can see the myoma. This myoma arises from the left lateral wall, and estimation of the size by hysteroscopy is not always very accurate because you don't have a measuring scale here, but you can compare the size of the myoma to the size of the uterine cavity. The normal uterine cavity is about 4 centimeters, so this myoma is about almost half of the size of the uterine cavity, so this means it's around 2 to 2.5 centimeters. So explore all around, look to the boundaries of the myoma, know the attachment, and try to guess the degree. This is apparently like type 0, but when we start resection, you'll find a deep intramural part, which is like type 1 myoma. Well, so let's start resection now. The basic movement of the resectoscope is 2 types of movement. Just focus with me. The working element, which works like the pistol, okay? You put your 2 fingers in the working element. When you move and you push forward, backward, forward, backward, the working element will push the electrode in and out, in and out. This is one movement. The other movement is the whole system, the whole resectoscope. So when people ask me, Osama, which one we do, you combine both. First, you push the electrode forward and have a panoramic view, then pull the electrode towards you from kefal to caudal. And when you pull the electrode, not all the way back like this, not like this. Because if you pull the electrode all the way back, you will bring this tissue, pieces to block the lens. So move the electrode only halfway back and then whole system out, okay? Again, that move the electrode towards you halfway, and at this moment, pull all the system caudal, okay? The landmark to know the level or the limit of resection is when you reach the myometrium. The myometrium looks different. This is the myometrium in front, which is pinkish interlacing crisscross muscle fibers. The myoma is solid white fibers. Again, the myometrium is, yes, this is the myometrium, and you can see this is the kefal part, or the inferior part of the myoma is still there. So, and also don't feel obliged that you have to take all these pieces of flesh or tissues of the myoma out. Keep working all the time in, because when you go out, the cavity collapse, some bleeding, blood clot, you'll not be able to see again. And now this is the scary step, is backward movement to detach the remaining part of the fibroid, and it is done. Push forward and up, forward and up. And now the small remaining part of the myoma is detached. Myoma is converted into all these pieces of flesh, and you can inspect very nicely the myoma bed. Make sure that there is no any residual fibroid tissues. And one more advice I tell you. When you resect the myoma, make sure that the base is even at even flat level, not up and down, because when the endometrium heals and cover this, you don't want to have a bumpy surface. So as you see here, I take what I call it potato chip slices, potato chips, to level the base, make it even flat. So like these pieces, okay? Look at that. That's the beautiful view of the myoma bed. to allow regeneration of the endometrium to cover and heal. And if you visit the cavity after a couple of cycles, 2 cycles, you have a very beautiful view. I decrease the inflow to check if there is any bleeding, and then go out after completing the surgery. Satisfied. This is the real time of the procedure, which is almost in the range of 5 to 10 minutes, and checking the myoma bed that there is no bleeding, and then you can clean and take all these chips out. This is Osama Shawki from Cairo, Egypt. Thank you very much.